All right, well, this morning we've got some content put together for the purpose of folks that work within our medical staff services and also in health systems across the United States. And the purpose of putting this content together is really to focus on the needs that we see emerging across the country as it relates to being able to get providers to the patients that need the most attention for care for COVID. So today what we're going to talk about is some takeaways that people can literally bring back to their different leaders, whether it be CMOs, CMIOs, folks that have to work with the technologies across the enterprise, but then also for their actual teams, the med staff offices, credentialing teams, enrollment teams, so on and so forth. So as we get started today, I want to say thank you very much to Rob for hosting and buying out the time to be able to put this together. We have an opportunity really to give back to the communities that we serve. And so from my perspective, I have been working with people across the nation for many years as it relates to provider data. And I've had the privilege of working with some of the largest health systems and health plans in the nation. And so as such, I've had an opportunity to really make connections with med staff folks, people from the credentialing space, and it's been an absolute honor and privilege to be able to work with them over the last 15 years. So anytime I have an opportunity or I receive an invitation to be able to speak or to share industry articles, and it has a benefit for those audiences, I'm absolutely in. So I appreciate the invitation to be able to speak today.
Oh, you're welcome. I appreciate it.
Yeah, and before we talk about some specific things we see taking place in the United States to be able to meet the needs and to look at innovative solutions that we see forming across the country, let's take a moment to first look at other countries across the world that were responsive to the needs that they had to be able to provide patient care. And Taiwan is a specific example that was actually highlighted in a presentation earlier this week that was hosted by an organization called Alpha Eagle. They had a provider, a doctor from Stanford, that was presenting a particular use case around the way that Taiwan was able to meet the needs. And so they didn't hold back. They immediately started looking at opportunities to expand how they were using data. And so for the folks that work within our health systems across the nation, they have powerful data that's available to them, but they don't always have all of the data that they need to be able to find the right providers that they need to be able to meet the needs that they may have in their geographic area. So today we're going to focus on some innovative activities that are taking place across the nation, specifically talking about 2 use cases. We're also going to pepper in some takeaways that you can bring back in terms of resources that you can use within your organization. But let's briefly take a look at that use case in Taiwan. We see that people really started to approach the situation as rapidly as possible and trying to identify how we can meet the needs. So when you think about healthcare in the United States and you think about the health systems that are being impacted with the need to be able to find providers, what we see taking place across many of the states is that folks are looking at their existing medical staff. They're also looking at providers who are part of their ambulatory medical groups, and they're trying to bring those providers from the ambulatory settings into the inpatient settings. But that's not a strategy that works for all states, especially in states where providers are not employed. And so we have to look at also the need that's taking place across the country, where even if you take the approach of bringing on ambulatory providers, you become limited on the types of specialists that you may be able to draw from that pool. You may also find that because of the crisis taking place across the rest of the country, there are many recruitment organizations that are out there drawing those providers away from the communities that they live in, and they're recruiting them for crisis care in other states. So the states that have been proactive in rapidly looking at what kind of a strategy that they can put in place are the states that have been able to secure not only the near-term providers, the providers that they anticipate they need right now, but they've also set up the protocols in place, the strategy in place for the midterm in the event that things turn into literally a catastrophic situation similar to what we see taking place in New York and New Jersey. And then finally, also looking, setting some of these things aside, but also looking at a longer term strategy so that in the event that there's disasters, additional disasters that take place in the future, they have the data that they need to meet the needs of finding who these providers are. So part of what Taiwan did is they put in a strategy in place to address those immediate needs. And they put in the midterm as well. You can see from the timelines that they put forth a plan for the next several weeks. And so that's what we're looking at today is what do we see emerging across the country to meet the needs? And you can see some of the examples, within our own walls of an organization, within our own databases that people have access to within our own systems, lies the opportunity to really tackle the need to expedite getting the providers to the patients that need the care. So let's start to dive into some of the things we see taking place across the country right now. And the first use case we have is actually coming out of New York. So in New York right now, data is being used in a way that previously it hasn't been. And these are not solutions that take weeks to months to put into place. They're solutions that literally can be put into place immediately. Just one moment. So by partnering with data that organizations already have access to, in many instances, outside of the medical staff offices or outside of the credentialing teams, there are also people who work in the analytics space. And a lot of those analytics teams have access to other types of data from outside organizations. And we won't get into the technical terms as to what this means, but in essence, they may have partnerships with different industry vendors. And in the healthcare space, there are dozens upon dozens of these industry vendors that are out there that have data available to them that is oftentimes able to be integrated into electronic medical record systems so that providers can gain access to the different tools that they need immediately in order to mobilize and start to provide that patient care. And it's not something that takes days to weeks to get into place, but instead it's something that can be integrated immediately. So I would certainly recommend that if folks don't already have a firm footing in this space, that they take a look at putting this in as a mid to long-term strategy. And I can tell you from personal experience that right now, a lot of these types of business partners, and this is just an example of one because they brought these use cases to the table. I'm using LexisNexis as an example, and they're the ones that are implementing this particular solution. But as I mentioned, there are dozens out there. I can tell you that right now, it's definitely an opportunity that if you had it on the horizon to partner with any of these organizations, they're being absolutely accommodating to the needs of healthcare organizations, negotiating some crazy discounted deals, opening up databases that they wouldn't otherwise to be able to get data to the people that are needed right away in order to have these key decisions made. So let's talk a little bit also about finding the right providers. So in this instance, we assume we have the providers. We simply need to get them into the system as quickly as we can. But what if you're in a market where you can't get those providers or you don't have the specialties that are needed? Let's talk about a solution that's actually working, that's in place with organizations across the country. So what I'd like to do is share 2 slides with folks today. And in these 2 slides, we talk about populations of providers that are commonly known by a variety of different names, whether they're called community-based providers, whether they're called referring providers or classically known as non-staff providers. They have records that have been set up in the EMRs because they've referred patients to your organization or organizations for diagnostic testing, labs, those types of things. So the data around those providers, although it's not a wealth of data, already is housed within the electronic medical records systems. And that population many times represents 10 to 15-fold the size of your classic medical staff, which means that if your classic medical staff size is this amount, then tapping into the community offers you a huge number of providers. But a lot of times people say, well, how are we even supposed to find those? And it's often known also that in those EMRs, this particular population of providers isn't really tightly managed. The governance structure around it isn't heavily in place. And so if you have within your organization other types of solutions, such as a master data solution or a source of truth solution, they can often also pull those providers. But at the end of the day, if you pull the providers from your EMRs, and then right now, you are probably all aware that the Federal State Medical Board has opened up its database and it's enabled it to be complimentary through April 17th. So by pulling these providers who geographically live in the area where you need to have care provided, and we'll go into a slide in a minute for all the benefits as to why this population is very powerful. But once you pull that information, you can quickly upload it to the FSMB. And from there, then you can look in partnership with your leaders, because what we've found is that many of the leaders across the country already know what kind of specialties they're anticipating needing. So you can pull from that to see what kind of specialties they might need. And then you can hand over a pre-validated set of data, because as folks know, FSMB, although it's not typically used as a primary source, it does include things like sanctions. It includes the state level licensing to see if there's any restrictions on licensing. It'll list all the states that they hold a license in. It will also include board cert in the event that you're not doing disaster privileging and maybe you're doing expedited instead. Then it will hold the board cert information, the MOC information if that's necessary. And so you can pre-validate a lot of the information in order to get those certain specialties prioritized and sent over to the medical staff offices. So the medical staff offices aren't tasked with trying to call retired providers, and they're not tasked with all this auxiliary work that takes up their time when they're under pressure to be able to really just focus on the providers that have the strongest need to get out to the patient's bedside. So the other benefit of taking this particular approach is that, as we mentioned at the outset, the electronic medical records are already set up with that provider information. So you can partner with the teams that manage those records to convert or modify those EMR records and make them the attending and admitting that they need to for the various different acute care locations where they would be affiliated with. So let's talk about some of the benefits. There's tons of benefits, but the ones that are very clear in using this particular strategy are included on this slide right here. So I'll let you take a look at this. Obviously, right now, as different states are trying to put out a plea for providers, they're having to enact crisis travel. You'll see a lot of the advertisements and the recruiters are talking about increased rates, but then you also have to consider, where are you going to put these providers? You have to be able to create space for them to be able to have rest and recovery, even if for short periods of time, and that further taxes the organization. So by using the providers who are already familiar with the geographic area that they live and they provide care, then it reduces the burden on the organization to also add the additional housing, food, so on and so forth. Although we know that Stark has relaxed its rules during this crisis, at the same time, this really does prove to be a strong partnership. I'm going to take you over here as well to the system, the health system as a whole. These providers know the communities that they're serving in, and oftentimes they've established their own networks and their own ties with other providers and specialties. And so by using the providers or partnering with the providers that live and serve in your community already within their practices, they're familiar with the area, they can more rapidly make referrals and connections, and they're not in an unfamiliar territory and trying to make those connections. They're also often familiar with the acute care facilities because at times perhaps they've followed patient care over the years in the past. And then finally, as I mentioned before, you're able to provision that access more rapidly for those providers. So for those attending today, part of what I've put together is a plan to be able to get these providers to the bedside in approximately 72 business hours. And so I'm happy to share those notes with participants, but that is something that is working in communities across the country. So at this point, what I'd like to do is I'd like to share some additional considerations that people will need to be aware of with all of the changes that are taking place. And I'll introduce some resources as well. But one of the things that I wanted to emphasize is that really you can look in the organizations that you serve, and you can see that it's not just the medical staff offices, it's not just the credentialing teams. There's a wealth of other teams in your organization. We talked a little bit about the types of data that can be used when I used the example of the New York illustration, where they were partnering with external data. And I'm happy to also provide, a list of who those different, vendors or business partners are that have very strong reputation in the space, in the event that that's something that you want to then take back to your analytics teams and say, do we have an account with these people? Do we already have subscriptions to these things? Because now is the time to tap into those additional data sets that have information about these populations of providers, especially with the community-based providers. So we'll talk now, we're going to transition slightly into a few slides that are going to talk about other teams. As we know, people who work in the credentialing space also are responsible for having to communicate with the downstream teams. And so they may be processing, expedited emergent disaster privileging, but it doesn't end there. At that point, there's a handoff that needs to be made. And organizations have varying degrees of processes that are in place for this. Some organizations have it automated where they do their data entry and everything takes place within a certain amount of hours or moments. But if you don't work in an organization like that, then you have to make sure that those handoffs are taking place under the timeframes that you need. And so reaching out and partnering, being proactive, and reaching out to the leaders who oversee the EMR has advantages because those people can then take handoffs from you. They can set up processes in place so that they can make sure they have enough staff in place in order to get all of the provisioning done so that those providers can provide care without hindrance, and they can navigate through all the different tools and applications that they would need to be able to provide the care. So this slide just represents some observations that are taking place across the country to help mitigate areas where there's bottlenecks that are occurring in the process. And then the next slide talks about considerations that those folks who support the analytics, so whether it is someone within your team that helps create the provider source of truth or the provider database, or the people who support the reporting needs, this particular slide highlights some of the things that we're seeing take place across the country right now, where as a result of the changes that are taking place, there's considerations downstream that are going to impact us over the course of 2020. And so you can see right away that there's going to be state licensing dates. And so a lot of systems that are connected to your credentialing applications, look at those state license dates and expirable dates. And if those expirable dates are being able to be laxed, or they're able to expire, you want to make sure that there aren't downstream processes in place that either cut off a provider's access or change how information is reported on that provider. Obviously, with your span of control in the medical staff offices, using the credentialing application, you definitely can communicate within your own teams. But when you think about those outside of your teams, they may take adverse action in the event that they see something that they weren't aware has since been changed. Another example that I might highlight would be if you look down, actually might be on another slide. Let me take a quick peek. So we talk about DEAs. The other one, I would draw your attention down here. It's right here. So one of the things that typically was not previously allowed, and I think I mentioned it on the slide before for the EMR considerations, is that it used to be that home addresses were not allowed. And so if a home address came through like an electronic medical record system and they were doing a validation process, they would kick it out and they would reject it. So one of the things that needs to be communicated is that because we're seeing the influx in telehealth, that home addresses are actually now being allowed to be used. And so making sure you communicate widely across the organization for any of the teams that need to know about this, they need to get the changes in place on their end. So again, there aren't negative consequences that weren't intended to take place. You can see some examples of different vendors down here that I had mentioned, or business partners, or databases that I have mentioned that are now open and available. So I wanted to make sure that those were listed for folks down here. And certainly, as I mentioned, there's a broader list of potential vendors that if you want to find out if your organization already has a partnership with them, I'm happy to provide after this recording. So right now, I want to transition and share some additional resources. I know that probably everyone, like me, is reading everything that they can find, trying to keep abreast of every single change that's taking place. And certainly we're seeing some of the big industry leaders in this space, whether it's with your credentialing system or if it's with national organizations or consulting firms that are very well known, they're being proactive in providing content. A lot of the content, though, we're finding is very similar in nature. And so they're touching on kind of the same things when they talk about different forms of credentialing and privileging that can be used, or cross-referencing kind of the same topics. So what I wanted to do instead was to bring to light some other types of resources that folks have available to them that especially larger organizations are tapping into and that they're using. So let's, the slide that you see on the screen is actually, I heard this quote on MSNBC a few days ago, and it really resonated with me because you think about the illustrations people are using where they're saying that our providers are, you know, first defense, first line, front line responders. And you think about it, there isn't anybody behind them. There aren't people coming to relieve them. So we need to do what we can to stand behind them and to be able to support them and to be able to get all the resources that we can get in place for them. So the next set of slides that I'll be sharing with you, again, like I mentioned, are different kinds of resources that I've found that folks have had a strong appetite for. And there's many, many, many. So I had to limit the number of examples that I shared. I think I've got 4 or 5 that I'll share with you guys today. But I wanted people to be aware that certainly CMS has been publishing quite a bit of information. But if you're like so many where it's difficult to be able to attend events live, you've got demands that are unexpected that come up, and perhaps you need to catch up on the information later, then CMS is actually recording and making the information available so that folks can tap into it on demand when they need it, and stay abreast and current with things that are taking place across the nation. And then the next one down, this particular organization, again, it's kind of similar to a LexisNexis, a Definitive Health. It's one of those vendor partners that exist out in the space that their sole purpose is to provide massive data to organizations. So First Data Bank, FDB, has actually been incredibly proactive in putting together a list of the different kinds of medical devices, and they're managing the content, and they're updating the content for subscribers. So if your organization is in a position where you have supply chain issues and you're still having difficulty getting some of the needed PPE out to your providers and to your clinical staff, then this particular link has been awesome to use. You can upload the spreadsheet, and then if you're a subscriber to it, they'll actually push the updates when they've created new information about new supplies that are coming and are available. And they're not only using, you know, the big name suppliers, but they're also partnering to crowdsource from other organizations to really provide a robust data set. So this may be of interest to your supply chain leadership within your organization. And I've included links for all these different things for folks as well. So while it might not necessarily be of direct interest to folks who work in MedStep offices, enrollment, credentialing, and certainly you may not have, you know, privileges tied to COVID, the ICD-10 codes, we do want to call out that there are still additional codes that are being brought up even as of last night. And so in order to keep that information current, then the COVID codes are being published, and we've got a list of the COVID codes available for folks. And then finally, I mentioned early on that FSMB is free through April 17th. So if you haven't already gone out and asked to have an account set up, please keep in mind that it's taking about 24 hours. The process includes sending an email to them, and I've included the link right here. So you send an email to them, you let them know that you're part of XYZ healthcare organization, and that you have a need to be able to access the database to provide COVID support. And so once they confirm that you're an authorized organization, then they will send out a link that allows you to access the database. You'll want to make sure that you just set up a centralized account. There's no need to ask for 100 accounts for people across your organization. In the event that you perhaps don't have a CBO, or in the event that you have an analytics team that's going to be helping out with this process, maybe consider setting up an account that has generic terms so that multiple people can upload information. I want to call out to folks that, you know, at first glance, people may think, well, I could just go to FSMB and I'll just pull down all the providers from the whole country and I'll use that. But really, the provision that they've made is so if you have providers that you need to do validation for, you can upload that provider's information, and then you can get your validated information back instantly. So when we were talking earlier about those community-based providers, you could potentially have tens of thousands of them that you would like to upload. And literally, they do give you that provision where you can upload thousands upon thousands of providers to get back the validation information and the validation results. So you don't have to have people from your teams doing a one by one, a one by one, a one by one. You can just do it in bulk. You can get the results back. You can sort them based on specialties that your leadership is specifically honing in on, as I mentioned. And then at that point, you can proceed forward with any of the other processes that your organization needs to put into place. And so this particular database, as I mentioned, although isn't often considered primary source, it definitely is proving to be of a great benefit. And so props to them for opening it up and granting access to meet the needs right now. The last slide I'm going to share with you today, before we open it up for some Q&A, is just an example of the different kinds, and I'll see if I can't increase the font on this just a teeny bit, but no, let's see, I'll bring it back down. This is just an example of one of the different partners that your organization may already have a relationship with, and or opportunity exists right now in order to be able to partner in getting in this type of data. The example that I have on the screen right now is an organization that's called Definitive Healthcare. In the last 10 years, they've made phenomenal changes in how healthcare can be delivered. And I'd encourage you to go out and take a look at their website. I have no ties to any of the companies that I've mentioned whatsoever, but I've just worked with their data over, the last 10, 15 years. In the case of Definitive Healthcare, because they're an organization that's focused exclusively on healthcare, the type of data that they're providing to clients, thousands of clients across the country, you can gain access within 24 hours to the data that's needed. You can pull down massive data sets from them. And so they're also doing, I wouldn't say special pricing, but I would say that they're open to negotiated pricing given the situation that's going on right now. And they offer powerful data through a variety of different things, whether it be, like I mentioned, just provider demographic data, claims data, ACO network data, kind of looking at your mid to longer term strategy as well. So this is an example of probably a dozen or more different organizations out there that are in this space right now. And that concludes the sample slides that I was going to share with folks today. I wanted to allow people a few minutes for questions if they had any. Otherwise, we can give the time back to folks this morning.
Yeah, I'm going to go ahead and unmute, or I will allow you to unmute yourselves if you want to ask any questions. I did have one question. There was a request for you to, if you could share the slide, the PowerPoint presentation.
Sure.
There was a way that we can, either we can publish that to the group, or we can just email it, however you prefer.
And Rob, is it for the full slide deck, or is it for a particular one of the use cases in particular?
I think it was for the PowerPoint, the overall PowerPoint.
Oh, okay.
Just as a reference, reference material.
Sure. Okay.
Hi, this is Karen Vineyard with Envision Physician Services. Thank you for putting this together. I do have one question for you. Do you know, or do you know where we could find this information readily easy? Are prescription requirements waived for clinicians who are not enrolled in the state Medicaid program due to the COVID?
Karen, I've got a number of resources that I've aggregated together. So what state are you in?
I am in Michigan, but we service all 50 states.
Oh, okay. Okay. Let me put something together. Are you in the Facebook group that Rob's an administrator for?
I am, and I also provided Rob my email address. I was the one that asked the question about providing the slide deck.
Okay, great. So what I'll do is, since you're in that group, I'll also start a DM with you to get you additional information and resources. Okay,
perfect.
Awesome. Thank you. Okay. What other questions do we have from the group today? If you want to hear about things we're seeing in the space.
Let's see. I don't know that I have any in the actual group itself. I don't think we have any more here. I think.
Are there, I was going to ask, are there topics that come to mind that people are facing within their organizations that they're looking for ways other healthcare organizations are approaching those needs?
I think the biggest challenge for a lot of people, and this is whether you're in the provider enrollment space or the medical staff space, is just nobody really knows what's going on, right? There's a lot of information swirling around.
Right.
And one of the reasons I wanted to do this, and I appreciate you putting this all together and sharing this with everybody, because I think aggregating information like this, it helps tremendously, because there's so much of it out there, and you don't know what is real, what is just, rumor. And everybody's still trying to make it through the normal challenges, as well as keep up with the new challenges, and reference and all of that related to the exceptions, the loosening of regulation at this time, and trying to do everything the right way. This is a very rigid industry, so we're not really used to cutting corners. And people take a lot of pride in what they're doing, and I think that they worry about making exceptions here or there and being able to justify those exceptions. So if they do something, if they do make an exception, that's fine, but it's like anything else. You need it for the file, right? They want to be able to show when they have an auditor come in and say, well, why did you do this? Well, here's the piece of paper from CMS that said I could do this.
Right.
And I think that's a big challenge for a lot of people, is just compiling all of that.
And I'm seeing the same thing happen, where I see organizations that are, they're enacting disaster privileging, and then they're not using volunteers for that disaster privileging, but instead they're transitioning folks from an ambulatory environment and extending those admitting privileges to them, and assigning them out to a variety of different acute care locations. So I see what you mean, and that's like one example of many that I'm seeing.
Sure.
I think at the end of the day, the piece that I'm seeing is folks are really trying to draw back into the space where they have influence, and because it's safe and it's what they know, and they know their world, in the case of maybe credentialing med staff professionals. But if you're in a health system, now is not the time to draw back in. It's the time to open yourself up, push out, and to look at those downstream processes. Because I'm sure we have all been in this situation where healthcare organizations pull the key subject matter experts into a space, and they make you document that process flow so that they can improve onboarding for providers. And so you're probably all aware of what the handoff looks like, and how it takes so many days and so many hours to be able to actually get that provider to the floors, get them their education, their access. And what we're seeing is that unless you live in a geographic area where you've already been hit with so many disasters that you've leaned that process out, that it is so fast, what we're finding is that organizations are pulling back into their sphere of influence, and then they're not creating those handoffs and making sure that those handoffs that would normally take a matter of days are being able to be expedited, truly expedited, so that they can take place. And then you have providers who've pushed to get all this paperwork and push to get the process done. You've got senior leaders who are pushing to get them into the system. And so you have all this pressure. You've got your teams working long hours to get the provider into the system and the validations done. You've done your part, and the rest doesn't happen in the timely manner. And so it's like an opportunity really to look at those innovative solutions. How can you pull the movers and the shakers? How can you pull them together and really role model and really lead? And so I know that people in our credentialing teams, our med staff teams, are phenomenal human beings. And they absolutely have the skill set to do this. It's just a matter of being able to prioritize the time, making sure that process is smooth, and then stepping back to doing what you do best.
Yeah, I liken it to a bunch of people trying to hurry up out of an exit door, and everybody's pushing on from their respective position. But the problem is that the door opens inward, and sometimes the process can actually get even more disjointed. Because even though we can speed it up, you made an excellent point. Even though you can speed it up with all these different resources and different accommodations in your piece, it is that transition part that is usually most affected when times of crisis occur. And that's where those delays and those gaps begin to reveal themselves, because it's everybody's very focused on how to do their job better, not so much on how it relates to other entities. I think this is a great time if you have a process like that, because it normally spans different divisions too. If you have a new provider that's coming in, you might be able to zip them through med staff, but they have to be able to get through the doors. They have to be able to have access. They have to be able to have EHR and all that.
Yeah. I've seen huge health systems that have the automated processes in place, literally where the data goes from the credentialing applications directly into the systems that do the provisioning, but it wasn't designed for the speed needed. And so that's where buying out the time, pulling those right players. And don't get me wrong, those senior leaders are absolutely invested right now. So often you already know who they are. Pulling them together and saying, I need a quick 30 minutes with these people. We need to validate and make sure that this process is working in a timely fashion has proven to be a huge win for organizations that are having to pump through volumes and volumes of providers,
So would you suggest somebody, essentially an ambitious type, raising their hand and basically saying, I want to put together a process to kind of quarterback the whole thing?
I would tell you that what I've seen is organizations have often already identified who their triage leadership needs to be in this instance. So like the crisis leaders, right? The C-suite, certain medical staff that are from the C-suite or who've been appointed for this, connecting with them and saying, I need someone, not the med staff directors or enrollment directors, but instead saying to that leader, we may have a need. I know that you have people in the organization or either project managers, they're Six Sigma certified, the people who understand how these workflows function, and asking, can I please use those folks? Or could you delegate to those folks to be able to make sure that this process and these handoffs are taking place in a timely fashion so that we can step back and focus on the things that we're responsible for. And then just simply illustrate, share the story without, I'm not one for complaining, I'm one for being proactive and getting the attention of the leaders. And so sharing with the leaders, this is what we need. The leaders will find you a project manager. They will find you a Six Sigma. They will find you an organizational readiness. They've got all sorts of different titles, change facilitator, who will step to the plate and they will lean the process out and they'll do the workflow to make sure the handoffs are taking place. And then you can either rest assured that things are in place, or you can highlight the need and allow the leaders to then press on to make those changes in that space. But that's a way to do it without owning it, without owning more stress, without owning more responsibility, even longer hours. It's a way to tap into the bigger circle and give people things that really they're looking for ways to contribute right now.
Okay, that makes sense.
So.
And I think there's probably a lot of resources, even on the admin side. I know that in our local health system here, they were furloughing a lot of people who worked in the ambulatory surgical arenas, repurposing some folks, to be available. But at the same time, there's still a lot of people that are that could probably use the work.
Oh, for sure.
But
are well connected. or they're well
Right.
connected
They
in the
understand the
organization.
system. It's just they might be
Mm-hmm.
part of a system. You know, there are hospital systems around the country that are furloughing even physicians, especially surgeons, because they can't do elective surgeries, and they're in a tough position. So,
and yet that's an opportunity to use them in another capacity before other communities draw from them, and then when you need them, they're not there.
right. Well, I think
Go ahead, sorry.
The problem is twofold. I think you've got some areas where there are too many vacancies and not enough
Mm-hmm.
physicians, and then you have a lot of other areas where there are physicians that cannot do surgery or perform any kind of elective procedures or see patients right now outside of this. And yet there is not the excess demand in those areas. I mean, thankfully, there isn't.
Right.
But I think whether or not there is or is not at this time, it's still good to have these things in place because you don't know.
Mm-hmm.
You know, a couple of weeks ago, the mayor of New York was telling people to go out and go to the movies and act like normal. So these things can turn very quickly. And
Mm-hmm.
I would suggest that, and I'm no expert on medical staff per se, but I would suggest that if your system is not in a position right now where these types of things are necessary and an emergency, I still think that it would be a good time to utilize some of that excess staff and figure out a way to make it work in the event that it becomes a requirement or a need right now, or B, so that you've gamed it out for the next potential crisis. I mean, hopefully we never have to use,
Right.
but that we have a unique opportunity right now where everything else, the normal day to day, has been arrested from the normal process, and
Right.
and we have that opportunity. So I think we should use every bit of it to our advantage. And I think the information that you've laid out here is certainly a wealth of knowledge for people just trying to keep it all together. This is a great place to start if that's what you want to endeavor to do. So
yeah, absolutely. All right, Rob. Well, thank you for the time.
Thank you. I appreciate it.
Mm-hmm.
Thank you,
Look
everyone.
forward to doing some more with you in the future.
Yeah, we'll have to get some podcasts in the works. I'm out of my studio and I'm at home, so it's a little bit tricky, but I'm trying to get everything lined up. But I appreciate.
Well, we'll see how things go with NAMS later this year, because I've got several submissions in there for a variety of other topics. So
awesome.
In the event that goes virtual, then maybe we'll take it to the podcast.
Absolutely.
Okay.
Thank you, Bridget. Thank you, everyone, and
absolutely.
I will talk to you all soon.
Okay. Thank you.
Bye now.